Hello students. Welcome to part 3 of concepts of care for patients having hematologic problems. Okay, we are going to talk about leukemia and pro-leukemia. The most important first is to define the concept. Leukemia is an actual blood cancer that results from a loss of normal cellular regulation. So cellular regulation is the issue, leading to uncontrolled production of immature WBCs, which are blast cells, in the bone marrow. Leukemia may be acute with a sudden onset or chronic with a slow onset and symptoms that persist for years. In addition, there is a group of precancerous or preleukemic disorders that can progress to leukemia and are the myelodysplastic syndromes that also result from the formation of abnormal cells in the bone marrow. These abnormal cells are usually destroyed shortly after they are released into the blood, so they never mature 100%. So most patients with MDS have a decrease in all circulating blood types: RBCs, WBCs, platelets. About 30% of all patients with MDS eventually develop acute leukemia. Let's watch a video so we can better understand the leukemia, the signs and symptoms, the diagnosis, the treatment, to be familiarized, and then we will review generally to finally memorize all of this. Okay, so let's go and watch this video. Okay.
Today's topic is leukemia. Leukemia is a type of cancer that arises in the bone marrow and results in a high number of abnormal white blood cells. Leukemia can also be referred to as the cancer of the white blood cells. The white blood cells are a vital part of the immune system and are mostly produced in the bone marrow, although some types are produced in the lymph nodes, spleen, and thymus gland. The white blood cells are potent infection fighters, protecting the body from invasion by bacteria, viruses, fungi, foreign substances, as well as abnormal cells. The white blood cell normally grows and divides in an orderly manner as needed by the body. But in leukemia, abnormal white blood cells are produced from the bone marrow, which doesn't function like normal white blood cells. The abnormal white blood cells also divide too quickly, eventually crowding out normal cells. Leukemia is classified into a variety of large groups based on how fast it progresses, acute or chronic, and the type of cells involved, lymphocytic or myelogenous. In acute leukemia, the abnormal cells are immature and they increase rapidly, making the bone marrow unable to produce healthy cells. The disease worsens quickly, and therefore immediate and aggressive treatment is required. These types are the most common form in children. In chronic leukemia, the abnormal cells are mature, but they are abnormal white blood cells. These blood cells build up more slowly and take months or years to progress. These types mostly occur in older people, but can also occur in any age group. Lymphocytic leukemia affects the lymphoid cells that form the lymphatic tissue that makes up the immune system. Myelogenous leukemia affects the myeloid cells. These cells form the red blood cell, white blood cells, and the platelet-producing cells. The specific type of leukemia are acute lymphocytic, acute myelogenous, chronic lymphocytic, and chronic myelogenous leukemia. The most common type in children is the acute lymphoblastic leukemia, or ALL. In adults, about 90% of cases of leukemia are diagnosed, with the most common being the acute myelogenous leukemia, or AML, and the chronic lymphocytic leukemia, or CLL. Other rare types exist, such as hairy cell leukemia and others. Leukemia can spread to other parts of the body, such as the lungs, heart, kidneys. Causes. Leukemia happens when some blood cells acquire mutations in their DNA. This causes the blood cells to grow and divide quickly and to continue living when normal cells would die. These abnormal cells continue to accumulate and stop the healthy blood cells from growing and functioning normally, eventually crowding out the normal cells in the blood. Certain risk factors that may increase your risk of getting the condition includes smoking, a family history of leukemia, exposure to certain chemicals such as benzene, genetic disorders such as Down syndrome, previous cancer treatment with chemotherapy or radiation. Symptoms: fever or chills, easy bleeding or nosebleeds, night sweats, fatigue and weakness that doesn't go away, bone pain and tenderness, red spots on the skin, bruising easily, unintended weight loss, frequent or severe infections, swollen lymph nodes, especially on the neck and armpits, enlarged liver or spleen. Diagnosis and treatment. The following tests may be performed. A physical exam, where the doctor will look for physical signs such as enlargement of the liver or spleen and swollen lymph nodes. Blood tests to look for abnormal levels of red or white blood cells or platelets. This may indicate leukemia. Bone marrow test, where a sample of the bone marrow is removed and sent to the laboratory to test for leukemia cells. This sample can identify the type of leukemia and its growth rate. Biopsy of other organs, such as the liver and the spleen, can show if cancer has spread. Treatment. The type of leukemia, age, your general health, and whether cancer has spread to other parts of the body will determine the treatment option. Treatment options include radiation therapy that uses powerful energy beams, such as X-rays, to kill the cancer cell. Chemotherapy that involves using medication injected intravenously or taken orally to kill the cancer cell. Stem cell transplantation, where the diseased bone marrow is replaced with healthy ones, either from a donor, as in allologous transplantation, or you may be able to use your own, as in autologous transplantation. Targeted therapies that use medication to target specific pathways or vulnerabilities present in the cancer cell may be effective. Immunotherapy that uses treatments that help the autoimmune system recognize and attack leukemia cells. Thank you for watching our video. Please do not forget to like and share the video. Also,
thank you so much for the video and the explanation. So basically, we can understand right now much better what is leukemia and also how it's treated. I explained also that there is a pathway of different disorders called myelodysplastic syndromes that are also result from formation of abnormal cells in the bone marrow. These abnormal cells are usually destroyed shortly after they are released into the blood, so most patients with MDS have a decrease in all circulating blood cell types, and about 30% of the patients with MDS eventually develop acute leukemia. So we know about this and we have to consider about this. With leukemia, cancer most often occurs in the stem cells or early precursors leukocyte cells. So the cancer starts there, causing excessive growth of one specific type of immature leukocyte. In some chronic leukemias, the cancer cells may be more mature. So when we are talking about acute, that means that the cancer is developing very fast. The cells are not mature, are immature, versus chronic, where the cells are mature, but they are abnormal. That's the difference between acute and chronic. These cells are abnormal in the chronic states, and their excessive production in the bone marrow stops normal bone marrow production, leading to anemia because they are abnormal, and thrombocytopenia and leukopenia, reduced circulating WBC numbers. Since they are abnormal, they are going to die more faster, and the production of cells are gonna keep growing faster, but they are abnormal, so they are not going to fulfill their objective, that is providing good immune system, right? Often the number of immature abnormal WBCs in the blood is greatly elevated, but these cells do not provide infection protection because they are immature. Leukemic cells may also be in the spleen, liver, lymph nodes, and central nervous system. And with acute leukemia, these changes occur rapidly and without intervention progress to cause death from infection or hemorrhage. Something that I want you to remember is that abnormal WBCs are elevated because they are immature and they keep producing, but they do not provide infection protection. Okay, so possible risk factors for leukemia development include exposure to ionizing radiation, viral infection, exposure to chemicals, genetic factors, that was explained in the video. And also, chemicals and drugs have been linked to leukemia and MDS development because of their ability to damage DNA and disrupt abnormal cellular regulation. Previous treatment for cancer with some chemotherapy drugs increases the risk for leukemia or MDS development about 5 to 8 years after treatment. So that is something to consider when we take the patient history or the assessment. We have to consider if they were having chemicals and drugs um, that were linked to leukemia, because in the future they are going to have problems in the DNA. I mean, therapies, no? Drug, chemicals and drugs therapies in general. Um, there is an increased incidence of the disease among patients with genetic conditions such as Down syndrome, as the video was explaining, among other conditions. Now, leukemia can be cured, but the acute phase of treatment is long. Okay, so we have to consider the patients getting into the emergency care, then they are going to be admitted into the leukemia unit. If they are going for stem cell transplantation, they have to find a donor, then they have to prepare the patient, and that means to remove the bone marrow of the patient, to clean that area, and then to infuse, to proceed with the transplantation process. At this point, the only potentially curative treatment for MDS, the myelodysplastic syndrome, is the hematopoietic stem cell transplantation, as I was mentioning, which is often not an option because of an advanced age of some of other patients, right? So just as for leukemia, supportive care for MDS includes blood transfusion for anemia and platelet transfusion when platelets levels are very low. So it's supportive treatment. Depending one day the patient, you're going to take blood work and the results are going to become, in low platelets, thrombocytopenia, then we have to order, the doctor is going to order platelet transfusion. If there is low RBC for anemia, the patient is going to order RBC blood transfusion. Okay, so these are the types of leukemia. You have acute myelogenous leukemia, acute promyelocytic leukemia, acute lymphocytic leukemia, chronic myelogenous leukemia, and also you have the chronic lymphocytic leukemia. But in the acute in ALL and MCLL, both are having the Philadelphia chromosome positive. Okay, so that's something to consider when you see diagnosis and you want to differentiate what's going on. So what you are gonna assess in the patient history You're going to check for occupation, the hobbies, the medical history, the chemicals they've been exposed to, drugs, radiation, if they have an increase in risk for bone marrow injury. Um, you are going to check the blood count to see if the patient is in high risk for infection, um, how often they get colds, influenza, pneumonia, bronchitis, unexplained fever, especially in the last 6 months. Um, as we know, platelet function is reducing leukemia, interfering with clotting. So you're going to assess for bleeding episodes as nosebleed, bleeding from the gums, rectal bleeding, hematuria. Also, you have to assess the conjunctiva. When you have a patient in the emergency room, most of the PAs and nurse practitioners, even the providers, they forget to ask the patient to watch the index finger, and you move the finger from right to left so you can see the little veins, then in the conjunctiva that are starting to bleed. You can see that, so that will give you a hint that platelets are not in the normal levels. They always often has fatigue from anemia, so you want to assess for headaches, meaning that there is lack of oxygen in the brain, behavior changes the same, loss of appetite and weight loss. And this is sometimes related not because the patient doesn't feel that they need to eat, but it's because the amount of oxygen they have is it's going to be enough to perform only one activity at a time. So if they are walking, they are tired, they cannot, dedicate that oxygen for eating. So you have to observe for these factors when you assess for leukemia. Also, in the physical assessment, you're going to check for cardiovascular changes. And this is a good table, key features that you can take into consideration. For example, integumentary signs and symptoms. You're going to see the ecchymosis, the petechiae because of the platelets abnormal levels, the pallor of the conjunctiva, the GI signs and symptoms, bleeding, weight loss, enlarged liver and spleen, hematuria, bone pain, joint swelling and pain, the cardiovascular signs and symptoms, especially palpitations, orthostatic hypotension, dyspnea on exertion, of course, neurologic signs and symptoms, fatigue, headache, fever. So all of them, they are related um, to leukemia. When you examine the rectal area for fissures and test stool for occult blood, you have to consider that sometimes many patients with leukemia have reduced bowel sounds and are constipated because reduced intestinal blood flow, decreased peristalsis. But not only that, it's because their nutrition is poor, right? So if their nutrition is poor, they are not drinking enough fluids, they are going to become constipated, and probably they are going to develop hemorrhoids, right? So that's going to be one of the causes of bleeding. um, Also, the psychosocial assessment for leukemia, this hospitalization is going to make the patient to feel lonely and depressed, and he's going to concentrate on financial stress. Laboratory assessment for leukemia, we have to pay attention to the hemoglobin and hematocrit levels that are going to be related to RBCs, the platelet count, the abnormal WBCs. The count could be low, normal, or elevated. And we know if it's elevated, it's because they are abnormal cells, right? They are abnormal cells that are there, and probably their function is compromised. They are not functioning 100%, these cells, right? So the definite test for leukemia is going to be the bone marrow aspiration at biopsy. We know that. And the blood clotting times and factors are usually abnormal with acute leukemia, with thrombocytopenia. Reduced levels of clotting factors are common. Also, it's going to be a test for chromosome analysis. Sometimes some types of leukemia are having the Philadelphia chromosome. So this test helps to differentiate the type of leukemia. We are going to also have imaging assessment, especially chest X-ray, to figure out if there are some leukemic infiltrates in the lung. Skeletal X-ray help determine bone density loss. So in general, we need to prevent infection. We need to think and considerate the nursing care related to poor clotting, and also all the nursing management related to fatigue due to reduced gas exchange. So again, we have to remember that the WBCs are immature in this disease, and they are not providing enough protection. Okay, so infection is going to be a possibility, because even though the WBCs are high. So let me mention something else. Infection occurs through autocontamination. Normal flora overgrows and penetrates the internal environment. And cross-contamination. Organisms from another person are transmitted to the patient. The most common sources of infection are the skin, respiratory tract, and intestinal tract. Okay, so some providers are prescribing prophylactic antibiotic therapy to prevent infection after the patient receive high dose of chemotherapy, but this practice is kind of controversial. There is an article here, an evidence-based practice report. One of the statements in this article basically summarizes what I just mentioned. Prophylactic antibiotic therapy has not shown a consistent benefit and may contribute to increasing drug-resistant organism. Just remember, the chemotherapy is not only killing the bad cells or the causative agents, but also and also they are not the chemotherapy is not only erasing, right, trying to get rid of the bad cells, but also is getting rid of the good cells. So you want to keep organisms that is going to help you to fight against infection. And this prophylactic antibiotic therapy is contributed somehow, based on this report, to increasing drug-resistant organisms. The little organism, whatever is left in the bone marrow, is going to be drug resistant with this type of antibiotics. So when we are assessing a patient for infection, we need to think about patients that are having allergies, chronic diseases, especially patients that are having poor nutrition, use the alcohol, tobacco, recreational drugs. Also, we are going to assess for nodules, lymph nodes, especially in the axillae, under the breast. We are not finding lymph nodes under the breast, but under the breast is an area that nobody assess, right? And usually there is bad odor there, and the patient is sweating there, so the bacteria can grow easily in that area, right? We are going to check the head, eyes, ear, nose, the cardiopulmonary, the characteristics of the sputum, if it's green, yellow, if it's red, we know that some pneumonia could be happening, the gastrointestinal, the rectal bleeding, the hemorrhoids. You never ignore hemorrhoids, never, because it could be the entry for bacteria, especially if the skin is having a breakdown. Genitourinary, vaginal, penile discharge, vaginal bleeding, characteristics of urine, and drug therapy for leukemia is divided into different therapies. The induction therapy, which is intensive combination of chemotherapy, started at the time of diagnosis. Then you have the consolidation therapy, consists of another course of either the same drugs used for induction at the different dosage or a different combination of chemotherapy drugs. This treatment occurs early in remission, and its intent is to cure. So it's like trying to solidify the state of the bone marrow or the immune system, right? Hematopoietic stem cell transplantation also may be considered depending on the disease subtype and the patient's response to induction therapy. Maintenance therapy may be prescribed for months to years after successful induction and consolidation therapy. Some common drugs used for leukemia are imatinib, and I'm not going to list the full list of medications and drugs, because all depends on the treatment, the type of leukemia, and the stage, right? But in general terms, you're going to find monoclonal antibody like rituximab, which is the most popular. Also, you're having allogenic hematopoietic stem cell transplantations in patients with CLL, chronic lymphoblastic leukemia, which is an option for cure or increased survival time of relapse, but has considerable risk for mortality and is not an appropriate alternative for all patients. That's why I highlighted this. I want you to understand also the difference between allogenic versus autologous stem cell transplantation. The allogenic, the donor is another person. Okay, hematopoietic stem cell transplantation is the most common example of allogenic transplant procedure. It could be from bone marrow, peripheral blood, or umbilical cord that they take the stem cells from, right? Carry the danger of graft versus host disease. The donor self perceives the body as a foreign invader and attacks the patient, which is the receiver. So in allogenic, that's the risk, versus autologous treatment, in which the donor is the patient itself. Okay. Um, Besides that, the patient, usually with leukemia, has different prescriptions of antibacterial, antiviral, or an antifungal agent. Um, Considerations, nursing considerations, and that's good to know. Hand washing is for everybody, not only for the people taking care of the patient, but also for the visitors, okay? And the visitors also must wear a mask when they are going to see a leukemia patient. If possible, the patient must be in a private room to reduce cross contamination. Um, Also, not allowing standing water in vases, denture caps. I wanna emphasize on this. When we admit a patient in the leukemia floor, they in some hospitals they are going to provide denture caps for the patient, right? In my personal practice, sometimes I saw that those denture caps were there forever and ever. I personally was changing the denture caps every 72 hours just to prevent, right? And I was putting a label on the denture cap, last change was on such a date. Because you want to prevent all types of possible causes for infection, right? What else? We have to monitor for the complete blood count, especially the absolute neutrophil count. We have to inspect the mouth during every shift for lesions and mucosa breakdown. Remember that when the patient is in the hospital, they are so tired, they are so sick, they don't even want to do the minimum hygiene, right? And we, the nurses, we need to be behind them in this sense. We have to provide, to make them feel comfortable, to provide hygiene. So this is a way to save their lives. Assess the lungs every 8 hours for crackles, whistles, and reduce breath sounds that indicate reduced gas exchange. Even the temperature in the room can produce, the minimum change in temperature. If they are not having enough covers, they can get sick easily. And talking about the temperature, and that's good to know. When we were giving reports to the doctor that were coming to the unit, even a minimal change in blood pressure or temperature must be reported, because hypotension, for example, and fever are the markers for sepsis. So you have to report change, a temperature elevation, or any drop in blood pressure, okay? Could be a sign of infection. Obtain blood for bacterial and fungal cultures from peripheral IV sites and the central venous catheter if you notice any changes. And these catheters and IV sites are going to be changed per hospital protocol every 72 hours. Sometimes other hospitals has other protocols, but for me, every 72 is a good protocol. Also check your urine specimens and try to agree with the doctor if the patient needs IV therapy, antibiotic therapy. Heart, lungs, kidney, liver. That's 4 organs that I will monitor through blood work, especially the lungs. With the lungs, I will assess for crackles, whistles, and reduced breath sounds. You want to check for pneumonia or something is going on. Your blood pressure, your vital signs in general terms. Check your creatinine, how the kidneys are functioning, your liver levels. So hematopoietic stem cell transplantation is a standard treatment for the patient with acute leukemia who has a closely matched donor on who is in temporary remission after induction therapy. It can also be used for some forms of chronic leukemia, MDS, lymphoma, multiple myeloma, aplastic anemia, sickle cell disease, and many solid tumors. Stem cells from transplantation can be obtained directly from the donor's bone marrow or more often from his or her peripheral blood. Transplantation has 5 phases, and this is just for general information. I'm not going to be testing you in this. Stem cell obtaining, conditioning the regimen, transplantation, engraftment, and post-transplantation recovery. You can check this classification of transplant, and I have provided this patient HLA identical twin. HLA stands for human leukocyte antigen. Typing is a genetic test used to match patient and donors for bone marrow, cord, blood, or organ transplant. So those are the tests they are going to do in order to find the right donor. Um, for allogenic, which is the donor is not the patient, is somebody else. The best results occur when the donor is an HLA identical sibling. However, transplant also can be successful between closely but not perfectly matched HLA types, right? Uh, so here, our cultural, spiritual considerations. Tissue types can vary among different regional ethnic groups. Disparity exists regarding the availability for diverse donors, such as it is important for donors to encourage more people of all races and ethnicity to become donors. That's very important, not only for leukemia, but for other, right? Bone marrow harvesting occur after a matching donor has been identified by tissue typing. And the marrow donation is usually a same-day surgical procedure, and you have to instruct the donor to monitor bleeding and take analgesics for pain, and they can take the donation from the peripheral blood stem cell and from the cord blood, um, or the marrow, right? Or the bone marrow. So here you have the timing and steps of allogeneic bone marrow transplantation, nursing action alert, safety, safety, safety. Do not use blood administration tubing to infuse stem cells because the cells may be trapped in the filter. Okay, that's good to know, resulting in the patient receiving fewer stem cells. Usually standard large bore IV administration tubing is used. Engraftment, the transfuse peripheral blood stem cells and marrow cells circulate briefly in the peripheral blood. The stem cells then home in on the marrow, forming sites of the patient's bones and establish resident there. So they find a new home. Engraftment, the successful take and growth of the transplanted cells in the patient bone marrow, is key to the whole transplantation process. For the stem cells to rescue the patient after his or her own bone marrow has been wiped out, as I mentioned a few minutes before, the stem cells must survive and grow in the patient's bone marrow. The average time to engraftment ranges from 14 to 21 days. This is only for engraftment, so consider the admission time while the patient is waiting for a donor, when after they have to wipe out the patient's bone marrow, and then the transplantation process, and then the engraftment. So is the patient's gonna be there, I think, 3 months at least. In addition to problems related to the period of pantocytopenia, low levels of all circulating blood cells, other complications of the hematopoietic stem cell transplantation include failure to engraft, development of graft versus host disease, and sinusoidal obstructive syndrome. Professor, in what moment is the period of pancytopenia? Remember, pancytopenia is the reductions of RBC, WBC, and platelets. So when after the team of care, they finally find the donor, they are going to wipe out the bone marrow in order to make the transplantation. That's the period of pancytopenia. Failure to engraft occurs when the donated stem cells fail to grow and function in the marrow. If the transplanted cells fail to engraft, the patient will die unless another transplantation procedure is helpful. You have to probably you are not going to work in the oncology, hematologic leukemia unit, but is very very probable is probably You are going to meet people that is having leukemia, and you are going to be able to advise about what type of therapies, or you are going to be able to understand what's going on with this patient. The This is the GBHD occurs. You can see this patient, right? Graft versus host disease. You can see the typical skin manifestations that are happening when there is a reaction, right? So they start attacking, even though they already did the match, and they try to find the most similar type of cells. If there is not a good engraftment, this is what's gonna happen. Okay. um, Management of graft versus host disease involves timing the activity of donor T cells by using drugs to suppress immunity, such as cyclosporine, methotrexate, corticosteroids. So they are going to try to stop the immune system activity. We are going to minimize injury. Bone marrow production of platelets is severely limited with acute leukemia, leading to thrombocytopenia. The patient is at great risk for poor clotting and excessive bleeding in response to minimal trauma. Thrombocytopenia can also be caused by induction therapy or high dose chemotherapy for transplantation. Correct. So the patient, what are we gonna do? What are we gonna do with that thrombocytopenia? The platelet count is decreased as a side effect of chemotherapy. So usually below 50,000, right? There are risks for bleeding, but below 20,000 is going to be a spontaneous bleeding. And below 10,000, we need to get ready for transfusion. Okay, those are the numbers. 50,000, risk for bleeding. Below 20,000, spontaneous bleeding is going to occur, in theory. And transfusion is going to be below 10,000, and that's good to know. So we need to assess every 4 hours for bleeding, enlarged bruises, petechiae or purpura, inspect stools. We have to double check for all signs and symptoms of bleeding, especially the conjunctiva. Don't forget about it. It's gonna give you that's a good hint about the platelet behavior in the body. Production of RBCs in terms of conserving energy is limited in leukemia and MDS, causing anemia and fatigue. So we have to um, uh, double think about how we are going to organize the activities for this patient. Um, and remember, the anemia may also occur as a side effect of chemotherapy. Don't put too many activities together. Activities means, wake up, get your breakfast, and now even walk from the bed to the bathroom. That's such a big activity for a patient that is having leukemia. And nutrition therapy is going to be needed to help the patient eat enough calories to meet at least basal energy requirements. You need to work hand to hand with a registered dietitian. Blood transfusions are sometimes indicated for the patient with fatigue, RBCs. Drug therapy with colony stimulating growth factors may reduce the severity of duration and anemia, and neutropenia after intense chemotherapy. And for anemia, erythropoiesis stimulated agents that boost production of RBCs may be used. However, drug alert, these erythropoiesis stimulated agents have a warning for causing hypertension and increasing the risk for myocardial infarction. They must be given with care and are avoided in patients with myeloid malignancies. Okay, what else? The best practice for patient safety and quality care to conserve energy are listed here. I highlighted some of them that I consider are kind of more important. So you have to teach the patient shortness of breath and palpitations are symptoms of overactivity. To space care activities, we know that. Schedule care activities at times. Provide 4 to 6 small meals. Urge the patient to drink a small amount of protein shakes or other nutritional supplements. Monitor oxygen saturation and respiration rate. All of them are done in order to conserve the patient's energy. And core care coordination and transition management. The patient with acute leukemia is discharged after induction chemotherapy and recovery of blood cell productions. So here I want to emphasize that you need to speak to the family that even though the patient is being discharged and the blood cell count is better, that doesn't mean that the patient can go back to their regular activities, okay? And the patient needs to follow up on the outpatient clinic with the proper blood work to see if everything is going normal and better. Patient and family education, preparing for self-management. You have the full list of activities to discuss with the family. Self-management, education, protecting the patient from infection at home is just as important as it was during hospitalization. And here you have the NCLEX question that basically you are going to check by yourself and you have the answer there. And what else? So we have to check for how we are going to provide proper care at home for leukemia patients. And that's all about leukemia. Thank you. This chapter I know is extensive and is a big chapter, but I am trying to provide with most of the information you're going to see in the NCLEX. Okay, so relax, take a breath, relax, a deep breath, and consider that what we are doing right now is going to save time for you when you prepare for NCLEX. Basically, I am trying to select and provide all the information that I know for sure is going to come on the NCLEX examination. So I'm trying to kill two birds in one shot, providing you information for this semester and prepare you for the NCLEX. Remember, I am killing two birds in one shot. When we come back, we're going to see malignant lymphomas, multiple myelomas, blah, blah, blah. Take a break.